I'll try and give you a brief overview of management of early non-small cell lung cancer over the next 10 minutes. And you just need to remember this one slide and the last slide, and you can go to sleep in between, and I'm perfectly happy with that. So currently we have 2.1 million cancers, lung cancers worldwide, which is more than 10% of all cancers, substantial number. 58% of them are in low and middle income countries, and more than 80% present in advanced stages. Out of these 2.1 million patients, 1.8 million die every year. It's by far the commonest cause of cancer deaths, and more than the next two cancers put together. Clearly, it's a major public health problem. So what I'll cover over the next 10 minutes is what should be the optimum treatment for early non-small cell lung cancer, what should be the extent of surgery, lobar versus sublobar, extent of lymphadenectomy, thoracoscopic versus open surgery, and I'll summarize. So surgery is the treatment of choice for stage 1, 2, and 3A. It's not based on very high quality evidence. It's just been what we've done all along. And unfortunately, I desperately hope I'm proven wrong, but there is not likely to be any randomized evidence to support this either. Chemoradiation and radical radiotherapy are typically reserved for situations where surgery is not possible. The new kid on the block is stereotactic body radiotherapy, or SABR, which has now coming up to be a fairly good option or an alternative to surgery, at least in some situations. Radiofrequency ablation has been not tested as well. There is no doubt about the fact that in a medically unfit patient who's not fit for surgery, stereotactic body radiotherapy is by far the treatment of choice. Multiple studies which show that it's superior to either external radiotherapy or a combination of chemoradiation. And what is actually seen at a population level is also that the number of patients treated with potentially curative intent has increased since the advent of SABR. The question now is whether in a fit patient, SABR or SBRT could be an alternative to surgery. And there are a number of studies, unfortunately not of very high quality. I'll just go through a few of them. The 5-year survival with SBRT in multiple series is in the ballpark of about just over 40%, which when you compare to surgery seems a little inferior. But I think it's an unfair comparison, because you pick the best patients for surgery and the ones who are unfit for SBRT, and clearly it's not a fair comparison. So there have been some comparative studies which have tried to have propensity matched cases and controls, and even with those, surgery seems to do better than SBRT. In a Monte Carlo simulation, 500,000 simulated trials, it's all just modeling, it's not actual studies. 85% of the simulations showed that there was a benefit for surgery, again demonstrating that we still lack the evidence to support SBRT. Another ASTRO presentation, this time by a radiation oncologist, unmatched SBRT versus surgery, hugely different survival, 68% versus 34% overall survival, but again unmatched, unfair comparison. But even when they tried matching, surgery seemed to do better than SBRT. So at least based on the evidence that we currently have, surgery seems to be the treatment of choice for early non-small cell lung cancer. We'll move on to the next question, which is what's the minimum surgery? And there have been a number of papers which have looked at limited surgical resection, primarily because lobectomy and pneumonectomy are major surgical procedures, and if you could do with something lesser and have the same outcomes, that would be preferable, especially because most of these patients have concurrent COPD and are not fit for a formal lobectomy. So the only randomized trial to date was this fairly dated trial. I believe Ophira worked in this unit with Bob Ginsberg. And this was a study which looked at T1N0, that's the earliest form of lung cancer, and randomized them to either lobectomy or sublobar resections. And what it clearly showed was that sublobar resections were inferior compared to a formal lobectomy, increased local recurrences as well as a reduced overall survival. This hasn't stopped people from trying for less radical surgery. There have been a number of studies, including some meta-analysis, which have looked at sublobar resections versus formal lobectomies. But the sum and substance of all of these is that, except in very exceptional circumstances, lobectomy still has superior outcomes as compared to sublobar resections. So the take-home point would be that lobectomy is the minimum surgery, and there might be a role for anatomical segmentectomy, no longer a role for wedge resections for tumors less than 2 centimeters. The next question is, what should be the extent of lymphadenectomy? This is something which surgeons obsess over, whether it's breast cancer, colorectal cancer, esophageal cancer, or lung cancer. I think we have very few things to debate, and this is one of them. And again, some few studies which have shown that lymphadenectomy improves outcomes. A very good randomized trial which came from China, which looked at a systematic mediastinal lymphadenectomy versus just sampling, showed 11% improvement in 5-year survival. Now, I'll challenge any of the medical oncologists, any of the radiation oncologists in this crowd to tell me whether any single intervention has improved outcomes by 11% in lung cancer. So by a simple procedure, very little added morbidity, very little added operative time, very little added blood loss, you're able to have such a major effect size. Unfortunately, a parallel trial which was going on in the US, the American College of Surgeons Oncology Group trial, showed that it didn't make a difference. Now, I could speak about this trial for half an hour and pick the number of faults that this trial had, which completely is at variance from what real life practice is. But nevertheless, this study showed that there was no difference. Fortunately, the meta-analysis proved it one way or the other, still demonstrating that systematic mediastinal lymphadenectomy should be done in operable non-small cell lung cancer. The final debate is VATS versus open lung resections. We are surgeons, we like new toys, robots, thoracoscopics, we like them all. So this is one area where probably the role of thoracoscopy would be fairly substantially beneficial for patients. And if you look at what a posterolateral thoracotomy implies, which is the alternative to thoracoscopic surgery, this is the kind of incision that you get. You have ribs forced apart with a lot of resistance and causing a lot of postoperative pain and pulmonary complications. On the other hand, you have thoracoscopic surgery, small incisions, telescopes introduced, instruments introduced into the thoracic cavity, and giving effectively the same kind of surgical procedure that's done inside. I wouldn't say thoracoscopy is the answer for all problems. It has a definite learning curve. It should be performed by a competent open thoracic surgeon. What we are seeing is increasing laparoscopic and thoracoscopic skills and incapable in open surgery. There should not be a compromise on oncological safety. The surgery you do inside the thorax should be exactly the same. And usually there are reduced complications after the learning curve. However, in India, with pulmonary adhesions being a problem, this could be something that we need to look at. So there have been some reviews and meta-analysis. Unfortunately, very few randomized trials. When the meta-analysis was done, we had 2 randomized trials. Now we have a third. The latest one, which was presented at the WSLC a couple of weeks back, which showed the latest randomized trial actually showed that there was a benefit with postoperative pain and earlier discharge. Now, if you ask me if it's a game changer, if it's something that's going to drastically change the way we treat lung cancer, I don't think so. It's just a one-day difference in hospital stay and a marginal reduction in postoperative pain, probably something that's not clinically relevant. But the meta-analysis is quite educative in the sense that they had a large number of studies, which with about 2,500 patients. But most of these were non-randomized, which brings in the element of a selection bias. And surprisingly, what the meta-analysis showed was that with most postoperative outcomes that you would look at after lung resection, air leaks, arrhythmias, pneumonias, and mortalities, though there was a trend towards improved outcomes with thoracoscopy, this wasn't a conclusive answer. And what you would expect as a much better, bigger benefit was not actually seen in real life. Oncological control fortunately was similar, so at least you're not doing inferior surgery by doing thoracoscopy, but hopefully with improving technology and improving skills, thoracoscopy might become a standard of care. All-cause mortality, again, more or less similar between the two groups, and importantly, 5-year survival also similar in the two groups. So I would end this debate by saying that though it has promise in reducing immediate postoperative complications without compromising overall survival, I don't think we are doing a disservice by continuing with open surgery. So to summarize, lung cancer treatment has evolved over the last 2 decades, and I think you'll hear more of this in the next talk when Nitesh speaks about metastatic lung cancer. The extent of surgery and mediastinal lymphadenectomy have been fairly well defined. Thoracoscopic lung resection is here to stay and has promise, and outcomes both in the short term and in the long term have improved. I said this is the most important side that you need to look at. In spite of all these advances, we haven't changed much in what we are trying to achieve. Still 2.1 million cases worldwide and 8 million of them dying of the disease. And I think if there is one intervention that we need to do, it's not better surgery, it's not better radiation, it's not better chemotherapy, it's advocacy against tobacco and primary prevention. Thank you very much for your attention.